Today I would like to speak about the relevance of accuracy in cervical cancer screening. The primary aim of the cervical smear test is to prevent development of invasive cancer and detecting precancerous lesions known as cervical intraepithelial neoplasia, CIN, which is usually asymptomatic and only found by screening. Treatment of CIN by ablation or excision of the abnormal cells significantly reduces the risk of invasive disease. The discovery of human papillomavirus in cervical cancer and its precursors has revolutionized cervical screening. HPV is a family of virus with over 100 types. Molecular testing studies of tumor tissue have shown that the great majority of cervical carcinomas show integrated viral DNA in the host genome, which is essential in the development of cancer. Low-risk HPV types are associated with condyloma, or genital warts, and are often transient. The immune system is mostly able to fight off the infection through apoptosis of infected cells and repair of damaged tissue through regeneration. High-risk HPV types have a greater likelihood of persistence and integration into the host DNA, and over time, show potential to develop into carcinoma. Cervical cancer is preceded by a pre-invasive stage. This stage of non-invasive disease is known as CIN and is directly related to the process of infection and integration of oncogenic virus material. HPV testing is not only recommended for triage of women with atypical or borderline cell changes, primary HPV testing is currently being introduced in various countries with or without cytology co-testing. The development and introduction of HPV vaccine will further revolutionize the practice of cervical cancer. Primarily vaccinated women are already entering the screening age, and the effect of reducing the prevalence of genital warts and CIN are being recorded. In countries where the uptake of vaccination is high, this is effectively reducing the incidence of HPV-related precancerous lesions and cancer. What about pitfalls in cervical cytology? A pap smear is a simple way to screen for cervical cancer. However, a pap smear isn't foolproof. It is possible to receive false negative results, meaning that the test indicates no abnormality, even though abnormal cells are present. The diagnostic value of smears for detecting precursor lesions of cervical cancer is determined by the quality of the sampling technique used. Inadequate sampling is often responsible for false negative results. Understanding the anatomy and histology of the uterine cervix is essential for the collection of a representative smear. The uterine cervix is the narrow lower segment of the uterus which projects into the vaginal cavity. It is a fibromuscular organ lined by mucous membrane. The exocervix or portio protrudes into the vagina and is covered with multi-layer squamous epithelium. The narrow endocervical canal inside is lined with monolayer columnar mucus-producing cells. The transition between the two epithelia is called the squamo-columnar junction. This junction area is where outer ectocervical epithelium meets the inner endocervical epithelium, and it is visible in colposcopy. In prepuberty, this zone is situated inside the endocervical canal. After puberty, as a consequence of a change in cervical shape, the use of contraceptive pills and/or under the influence of pregnancies, the endoluminal epithelium everts. This so-called cervical ectropion is visible as a red zone contrasting with the lighter pinkish color of the squamous portio. It is perfectly physiological during the reproductive period. The extent of the ectropion varies from person to person and from age to age. Gradually, this epithelium is then replaced by metaplastic squamous cells. The name given to this area of comprising epithelium that has undergone squamous metaplastic changes is transformation zone, TZ. This is the area where most abnormalities arise. Virtually all squamous cell neoplasias of the cervix arise initially within the transformation zone. Therefore, locating the transformation zone and sampling its entirety is essential to obtaining a representative smear. The Bethesda system for reporting smears provides categories for evaluating the quality of a smear, including presence of sufficient number of cells, presence of metaplastic and/or columnar cells, as well as squamous cells, absence of excessive numbers of red blood cells or inflammatory cells, and the absence of extensive cytolysis, as well as the absence of aggregation of cells. A smear suitable for cytological evaluation should also be labeled with identifying details and a request form that contains adequate clinical information. Recommendations for preparation and collection of the smear are: cytology samples should be taken at mid-cycle, not obscured by blood and endometrial cell shedding during menstrual flow. The smear collection should be performed on an examination chair for gynecological examination with stirrups. An adequate light source must be available. The physician taking the smear must be familiar with gynae examination and well trained in taking cervical smears. The speculum is inserted and the portia is visualized as clearly as possible. For the comfort of the patient, the speculum should be warmed. In the event of an extreme retroverted or anteverted uterus, the cervix can be manipulated gently with atraumatic forceps towards the center, enabling full visualization of the entire transformation zone for a smear to be taken. If there is excessive mucus, discharge, or blood, it should be carefully removed with a swab. Then, the cytobrush is inserted into the endocervical canal and gently rotated 90 to 100 degrees, allowing the bristles to come in contact with the entire surface. In conclusion, the experience and dedication of the physician taking the smear plays a crucial role in achieving an adequate, satisfactory, and representative smear. The collector effect is far more important than the choice of equipment. The effectiveness of cervical cancer screening depends on the following: detecting and removing precancerous lesions before they become invasive, deciding how to manage lesions that are likely to be reversible but are at some risk of progression, safely returning a woman at minimal or no risk to routine screenings after a successful treatment. The decision to treat and its effectiveness depends on accurate assessment of all parameters. Theoretical background knowledge and practical training in taking pap smears therefore needs to be a permanent feature of training programs in medical facilities. Ideally, a competence team of a colposcopy-trained gynecologist, a cytopathologist, and a histopathologist should discuss all non-invasive abnormal results in a multidisciplinary quality assessment.